because
That's a great.
I learned a lot through questions.
Same here.
I obviously like neurology question of the day, and if people don't use it, I think that's a great one. But because I learned a lot through questions. Oh, that echo. Sorry, I think I'm hearing my voice. Anyway, so otherwise there's board vitals. I know there's also the another one on the AN website. I always forget what it's called. I think it's SAE. It's pretty good. What do you use?
I'll pull up a list because I've been just keeping track of, when I ask people what questions and, resources they use, I've been piling them together. So let me find my list and then share it. But for me, yeah, I learn best with case discussions, and then correlating. If I merge them with like questions, then it just sticks so much better for me. So let me show you some of the resources that people have shared with me. So there's this Neuroscalps. Have you heard of that?
No.
So it has like 800 questions, has some videos. Now, I haven't used any of this, but it's just when I was asking people about questions. I think that's an old domain. Well, I'll have to take that off my list. This board vitals, is that the one you were talking about?
Yep, it's pretty good. It's free through the VA.
Oh, it's free through the VA.
Yeah.
Oh, okay. And does it have is it for like neurology?
Mm-hmm. Yeah.
Oh, cool.
Yeah. At least there's one for neurology for sure.
And then is that for residents? Is that for like the right and our board exam?
It's for the right. And I think it's pretty good. It's easier than what was the one because there was one that had an offer, so we did the trial. I forget what it's called. That was quite good, but let's see what it's called. Chou Learn. Have you heard about Chou Learn?
Chou Learn. I think I have. Let's see. There's the blueprint. Here's the right. Neuroimaging. Chou Learn. I think I remember, let me put that up. Can you send me the link, please? And then we can just pull it up. So Jonique, we, as residents, we have to take our board exams at the end of our residency year. But then as we're in residency, they have what they call a RIDE exam that we use as practice to kind of gauge, as the residency programs, can use to kind of gauge, where we're at and how, what are our strengths and weaknesses, so that when we take the boards at the end of fourth year, we have a higher chance of doing well. So.
Oh, okay. I have a similar exam for the residents to do, and then depending on the program, you have a couple of research papers that the residents do. But I'm not sure if they have a like you guys have, for example, the right, just to kind of gauge where you are. That's cool.
Oh, actually, if you want, Mattia, you can share. Oh, you can share your screen. Oh, look, Sion is here. Fantastic.
I've sent you the link to Chou Learn.
Oh, cool. I'll pull that up.
Hi, everyone.
Hey there.
Hi, how are you?
I'm okay. How are you?
Doing great. We're just talking about different test banks that we can use as for residents for our board study.
Okay.
True learning. So I guess for me, the question is, I guess I should, I could start using it now. Have you used True Learn?
So the two that I've used Board Vitals mostly. True Learn was having a sale, not a sale, but was having like a promotion about 2 weeks ago, and I tried. It was like a free 50 questions.
Oh.
And I thought it was pretty good. I like the layout of it. But also, I don't want to get to that point where, and I also tried SAE, and that's also quite good. But I don't want to get
free.
Those
well,
are
at
free,
least,
yeah.
Like with the AAN, and because I'm like all about trying to use all the free resources first, and then go and buy the test banks.
Yeah, but I don't want to get to the point where I'm just collecting multiple resources. I buy one Q bank, I have another Q bank, and then I I spend more time trying to figure out which Q bank to use than just using one and going from there. Kind of like, I don't know what you did for USMLE, but I prefer sticking to UWorld than using Kaplan and UWorld and all that, like sticking to one and going from there. Yeah.
No, that makes perfect sense. What I do is like I collect, I ask everybody what are they using, and then I'll look through, all the different resources, figure out which ones work for me by trial and error, and then, stick with one or two and then go from there. But then I had a attending say that this SAE one is really good, and it's it's quote unquote free through their membership. So maybe that could be, I would like to start incorporating, questions in our discussions as well, because it just helps it stick.
Yeah, and it's sort of the same as when you're on the wards, right? And you have one specific question and you learn that, right? Like when attending has a question, it's really easy to remember that as opposed to a whole chapter, right?
Exactly.
Yeah, I agree. Yeah.
So if anyone has any thoughts, or I'll start pulling up, some of the free resources. I think I have it in the schedule coming when we're done with all the neuro ICU big topics. I think I put in the schedule day 1 or 2 days for just like questions, and we can just boom, and it'll help the medical students for the shelf exam for step 1, 2, and 3, and then we can also do questions for residents as well.
Yeah, for sure.
Cool.
All right. Shall we move to, yeah.
So we can talk about the case. Let me just find it. And this really just talk about all of them. There's like 3 cases in here, so we can just talk about all of them, and hopefully in talking through these cases, we'll learn the management of subarach. So let me share my screen.
Very good.
I wonder how I can make this bigger. Okay, so we have a 46-year-old woman. She collapsed with jerking movements and vomiting. Went to the ED. She's in good health, but she smokes cigarettes. Doesn't take any medications. No history of drug use, and she's never had seizures before. When she comes to the ED, she's intubated and she's given 2-gram load of Keppra. They do a CT head. So let's go look at the CT head. So Jonique and Sion, how would you read the CT head? If you're on wards and the attending that pulls up this image, based upon what we talked about yesterday, how would you read it?
All right, so for A, I would say it's a CT scan, possibly non-contrast, an axial view, head.
Fantastic, good job.
I would say on A, what appears to be, well, I'm not sure what it is, probably choroidal, but I'm not sure if it's blood, a hyperdense area within the ventricles. But just anterior to that, I think maybe blood between the fishes, not the sulci, sorry, of the brain, not sure.
Very good, beautiful. And then, so what do you say about B?
All right, same axial view. Oh. So so hyperdense accumulation or area. I'm not sure exactly where to describe that as being located though.
Do you think it's in the brain or do you think it's in the ventricles?
Anatomically, I see ventricle. I would say ventricle surrounded by dark areas. So I'd say
Yeah,
ventricle.
that's what I would say too. What would you say, Mattia?
Yeah, I think it's the frontal horn of the lateral ventricles.
Looks a little central.
Yeah, I think, I think it may be the view and how the patient is tilted, right?
Okay.
It's kind of hard with us scrolling up and down, but I would, especially with that level of density, it looks, with like probably in a clinical setting, you just go ahead and sample and check the Hounsfield units, but it looks like more so like calcium, I would say, than blood, but it's kind of hard to tell. But I would say that all things being equal, I would argue that that's more so the frontal horn personally, but
Yeah, that's what I mean, because we have this, black space here, and if we go back to here, that's kind of where the the lateral ventricles would be. So I would say there's probably some, I call it interventricular hemorrhage would be what I would say. And then, as we talked about yesterday, the star pattern in the cisterns, and it's kind of around the midbrain as well. So then we go here, we just see more of the same. Maybe, yeah, that's interesting. Ventricle possibly, or maybe it's in the brain parenchyma. I'm not too sure, but it's bad. Ooh, Jonique, what's going on here?
Whoops, so sorry. CT scan axial view of a hyperdense area in the, well, I don't know, that's cerebellum. That's
Good.
fourth ventricle.
Yeah, very good. Good job. You guys sound like neurologists. Awesome.
Thanks.
So basically,
and that makes me think of a clot, right? So it makes me wonder whether it's the blood that's now in the ventricular system.
oh yeah, so they say here, acute hemorrhage was interventricular extension. A, B with the focal clot in the fissure, intrahemispheric fissure, and then in the cistern, and then the fourth ventricle. So it looks like all those this is clot. And then maybe this fourth ventricle is also a clot versus
clotted up, yeah.
Mm.
Because
Cool.
I guess that it's denser than you would expect with acute blood, right? Like it's clotted. Yeah.
You know what they say, like when you have something that's actively bleeding, you have that Oh, there's that sign.
Yeah, the swirl sign, right?
They're like, you know, like the, oh, it's gonna bother me.
Swirl.
You know how, the swirl sign, is that what it's called?
Swirl. Yeah, swirl sign.
Let me look that up. I'm a visual learner.
So whenever you have fresh blood, it's a bit hypodense, I want to say.
It's like a fluid level.
Mm-hmm.
Is that the
Yeah.
swirl sign?
Yeah.
No.
I-
This? Oh,
Yeah,
I've
it-
never heard of this before. Oh, this is interesting. Let's go to Radiopedia, see what they say.
Yeah, it should be an area of hypodensity, which is fresher blood, so lower attenuation than the clotted blood.
So it says the swirl sign refers to acute extravasation of blood into a hematoma. Extra blah, 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 represents, represents unclotted fresh blood, which is lower attenuation than, oh, nice.
Yeah.
Learned something new today.
And then
Wow.
there's the other sign, which is the spot sign, which you get with the CTA.
But then there's also another, like a fluid level that shows like you have hyperacute blood, and then you have you like this?
Mm-hmm.
So you have the swirl sign, then you have the this fluid level. So let me see, does Radiopedia, see what they have to say about it.
And there's also a third one, which is the spot sign.
Oh yeah, but that one's on CTA,
Like-
right?
Mhm.
Right?
Yeah.
Aims of coagulation presents blah, 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 blah. Fluid level, also known as blood fluid level. And associated, so do we only see this in patients that have a coagulopathy or anticoagulation?
You know what? I'm not sure actually.
Fluid blood levels and acute intracranial hemorrhage are moderately sensitive to the presence of a coagulopathy and highly specific for this condition. Oh, so check this out. I guess so. It says it's specific and sensitive. Thus, intracranial hemorrhage with a fluid level should prompt a thorough search for coagulation disorders. Interesting. Oh, so then the hyperacute blood is the black, right?
Yeah, I wonder why it's more specific for patients with a coagulopathy, though. I mean, obviously, if you have a coagulopathy, clearly you're gonna bleed more, but
That is interesting. Let's see, there's a reference, it's reference 1. Huh. Huh. I'm going to read more into this. Interesting. Cool. So now that makes sense. So CT head shows the diffuse subarachnoid hemorrhage, goes to the stroke center. Before she gets transferred, she has intact brainstem reflexes and is moving all of her limbs. So when she arrives, heart rate, she has sinus tach, blood pressure 180 over 110, temperature 100.4. She's intubated. pregnancy test negative, glucose 110. On train of 4 testing, peripheral nerve simulator for depth of neuromuscular block, she has 4 twitches, suggestion no residual effect of paralytic. So does that mean she's paralyzed or not paralyzed?
I think that means that she's no longer paralyzed, right?
Oh,
So
okay.
she still has, so she's twitching on it.
Oh, okay. But
Yeah.
if she was like 1, 4 or 0, is it 0, 4? Is that the lowest it goes?
I think so, yeah. Let's check that out.
On train of 4 testing.
Let's see. Let me have something here.
And I know when I was in the ICU, they would use this to see, you know, is it, or can we, you know, do a accurate neuro exam on the patient or not, or do we have to reverse? Do we have to reverse them?
Yeah.
Let's see. Okay, user says.
Train of 4. No. All right. A commonly used way of testing for the presence of neuromuscular blockade is train of 4 test. A series of 4 consecutive electrical stimuli are applied along the path of a peripheral nerve, and the resulting contraction of the innervated muscles is measured. Absence or diminished response suggests the presence of a neuromuscular blocking agent. So I think 4 out of 4 is the max. So 0 would be lack of response, which would indicate that the patient is successfully paralyzed.
Oh, okay. Awesome. Awesome. Cool. That answers that question. Nice. So then we get back to the discussion on exam. Patient cervical spine is immobilized. So after her propofol drip was stopped for 20 minutes, she's still obtunded. She grimaces symmetrically and slowly withdraws all 4 extremities to deep noxious stimuli. So she grimaces, so that means it withdraws to all 4. So her motor sensory reflex is intact. Grimaces and she withdraws, so that's good. Her pupils are unequal and reactive, so that means her midbrain, her cranial nerve 2 is intact. Cranial nerve 3 is intact, right? Because I'm just,
So slight mydriasis, although probably confounded by the medication she's on, but equal and reactive otherwise. So cranial nerve 3 is working.
oh, when her eyes are held open, she has forced down gaze.
Huh.
That's not good. So does that indicate like increased ICP, right? Or seizures, right?
I think, well, as long as it's not ocular bobbing, that's good. But yeah, I think you're right. So let me think. Because if I'm not mistaken, there's up gaze restriction whenever you have dorsal midbrain pathologies, right?
Dorsal midbrain pathology. Let's look it up. Because I know one of the first signs of, well, if we're concerned for someone that's having brain swelling or hydrocephalus, down gaze deviation. So up gaze restriction, equalization. Midbrain at
Because
level of,
I think that's also what you can get with the Parinaud syndrome, right?
oh,
Which is dorsal midbrain.
huh.
Yeah, so I think
I'm gonna look in one of my books real quick.
there you go. Found it.
Cool.
So let's see. There's this really cool resource here, which is on the Utah website. And you're absolutely right. So acute down gaze deviation would be common causes acute obstructive hydrocephalus from aqueductal stenosis, malfunction of the lateral or third ventricular shunt, and then thalamic infarct or hemorrhage. Uncommon cause is seizure. Seizure is more lateral gaze deviation, but it's not unheard of for it to be up or down. Hepatic encephalopathy, which can cause everything, as we know. I don't know if you get consulted as much as we do, but that's very common.
That's right. Sunset eyes. That's right.
There's a nice video too. Down gaze deviation. And I wonder if that's the same. I wonder if that's the same etiology of the dorsal midbrain syndrome, right? Because in dorsal, in Parinode syndrome, right, you get a supranuclear up gaze palsy with normal down gaze, right? And it's sort of the same place if you think about it, right? Because it's also around the aqueduct, and it's the dorsum of the midbrain. And these are the nuclei that control up gaze, right?
J81 TV.
Oh, we have another person that is
Wonderful.
joining us. Hello.
Welcome.
Hi. Feel free to introduce yourself if you would like. We're recording FYI on YouTube. FYI.
Hi guys, this is Aarti. I'm a neurointensive care physician at Wake Forest, Winston-Salem, North Carolina. Thank you for inviting me to this.
Welcome.
Oh, thanks for joining us. So we're right now we're talking about management of subarachnoid hemorrhage, and we're going through a Continuum article, and we are trying to figure out with forced down gaze, what's the localization? And so Mattia was showing us a cool resource that was talking about forced down gaze in a patient with subarachnoid hemorrhage. So feel free to chime in if you'd like.
So have we talked about the third nucleus often neglected in the oculomotor nucleus complex that is responsible for the downward gaze?
Oh, no, we were trying to figure out why people with elevated ICP have downward gaze. Like what's being impinged or?
So the top of the midbrain, the base of the third ventricle rests on it. So when you get irritation from subarachnoid hemorrhage, which is in basal cistern, or hydrocephalus with third ventricular enlargement, the top of the third nerve nuclear complex gets compressed. And the three nuclei in that complex, the oculomotor, the Edinger-Westphal, and the third nucleus is called the interstitial nucleus of Cajal, Kajal. And that is the conjugate center for vertical gaze. So people know about PPRF, which is the conjugate center for horizontal gaze, but the interstitial nucleus of Cajal is what causes vertical conjugate gaze. That's why the sunset sign in neonatal hydrocephalus, basal cistern subarachnoid, or any third ventricular hydrocephalus causes downward gaze.
And Arti, let me ask you if you don't mind, because I was thinking whether this is the same. Two questions about this. So, is the RI-MLF also involved? And is it the same pathophysiology as the downward gaze deviation in Parinode syndrome?
That's a good question. I do think the MLF is involved because the vertical downward gaze does require both eyes to talk to each other, and one nucleus can't control that. I will have to look up Parinode though to currently refresh my memory. Plus, I'm a little hypoglycemic post-workout, so let me think about it.
No, but thanks so much for your words of wisdom.
So I'm a visual learner, so I'm trying to find a good image that talks about the sunset eyes and the neuroanatomy.
I think I may have something if I can find it.
Oh, Mattia, can you share that link that you showed us a while back with the eye exam?
Yeah, absolutely. So this is an amazing website.
You're always so good with websites and good resources. Now I'm a fan of EM Crit. So now I'm going to be a fan of this Utah. Jonique and Sion, if you guys have questions, just feel free to chime in.
Sure thing.
I think
I'm going to try my localization books. My old school localization books is what I'm going to try to look for.
Nice. I think the big thing from a medical student standpoint is anytime you see someone that has downward, I think a good what's what I'm looking for? buzzword, downward gaze bilaterally, think elevated ICP. And as Mattia talked about, if you have like forced gaze deviation to the left or to the right, you think seizures. And I think at the medical student standpoint, if you can remember that, you're solid.
Or a pontine stroke. Don't forget that. You don't want to miss a basilar occlusion. Because remember, a pontine stroke can also cause lateral gaze conjugate deviation.
Oh.
Which, if I'm not mistaken, Artie, that's the interesting part about both pontine and thalamic, because usually we think of, so gaze deviation toward the lesion as being an ischemic stroke, like a large vessel occlusion, cortical stroke, and contralateral as being seizures. But then you can get contralateral also with thalamic strokes and with pontine strokes, right? The so-called wrong way eyes.
Yep. You can have anything that affects the PPRF can cause conjugate gaze deviation in the brainstem as well.
Oh, neuroanatomy.
So I think somewhere in here, I took a screenshot at one point.
So what localization books do you guys use? I'm assuming this generation doesn't read books anymore. But when I was in
books online.
let me show you. Let me show you my collection.
So this is my go-to Bible for localization.
I use,
What do you have?
It's
I'm gonna show you what the kids are using nowadays. I use Kindle.
Oh yeah, absolutely. Look.
Oh yeah, I have that one on. Let me take you guys to the 21st century. So here is my Kindle book, and I have it. Here's the Kindle version.
You have a Kindle version of Brazi's?
Yeah, because that
is so cool.
So it's like I'm all my books are on Kindle.
I need to hang out with this group more often.
Okay, so did anyone find a good image of where this localizes?
I'm still looking, but I cannot. Oh, there we go. Okay, I have it. I think, and let me ask whether Artie agrees with this, but I think this may be what I was thinking about. So this is for Parnell syndrome, but more so, I believe these are the nuclei that we're talking about, right? So this is the dorsal midbrain. This is the cerebral aqueduct here, and these are all the little nuclei. I think this, right?
You are correct. So even Brazi's agrees with you.
Do you have a good picture from the Brazi's, maybe, which is better than this?
So Brazi's was never very picture friendly, at least in my generation. It is one of the most text heavy, picture lacking books.
Let me see. What chapter would that be on? Since I have the Kindle version, I could look to see.
So it'll be the Oculomotor System chapter. It's chapter number 8 on my side. And I can read you through it.
Okay, yeah, let's see. So chapter 8, I found that. Let's see.
So it explains the hydrocephalus part with the dorsal midbrain syndrome, impairment of all upward eye movements. Although Bell's phenomena would be still intact, vestibulo-ocular reflex would be intact, which is the fun part of the localization. Your down gaze saccades and smooth pursuits may be impaired. And in hydrocephalic infants, there is tonic downward deviation of the eyes with the setting sun sign.
Hmm.
The lesion of the posterior commissure, which projects to the ocular motor neurons, basically causes the vertical gaze impairment that affects all classes of vertical eye movements, especially upward gaze. This constellation of findings caused by lesions in the posterior commissure is designated as Perinaud syndrome, Sylvian aqueduct syndrome, pretectal syndrome, or the other fancy name for it is the Kieber-Sallis-Olschnig syndrome. And this is more localized to the posterior commissure, but will have similar findings. So you're right.
So what we're seeing is essentially a form of Perinaud syndrome whenever we have. Interesting.
There's a very good segment on vertical conjugate gaze palsy in the oculomotor syndrome chapter. And it talks about thalamic lesions, midbrain lesions.
Gaze.
Yeah, it's oculomotor syndrome chapter. And there's a column called vertical conjugate gaze palsy. And then it walks you through thalamic lesions, midbrain lesions, Perinaud. And then it walks you through oculogyric crisis.
Oh, found it.
There you
So
go.
vertical conjugate gaze palsy. Midbrain lesions.
Oh, there you go. The RIMLF that we were talking about earlier.
Here.
And the INC, the interstitial nuclear canal. Yeah.
Let me change that. So midbrain lesion, upward, each contains first upward downward movements. Blah. Unilateral lesion can cause combined up and downward gaze palsies, perhaps by disrupting the bilateral gaze. So are we saying that it localizes to the midbrain?
Yeah, that's
Oh,
right
okay.
on the dorsal midbrain. And it's around the aqueduct, right? Which is what was involved in the picture too. Oh, this is beautiful.
Nice.
Yeah, I love Brazis. This has been my go-to book for anything localization.
Yeah, I used to use a lot the De Jong more so, which is good for examination, but for localization, the Bryce is incredible.
Yeah, I think there are some books that are good for exams, but Brazis is like not good for exams because on a single paragraph, every sentence has 5 facts to remember. So it's a great, it's a great Bible book. You only go to it when you're in a conflict and you want to solve something. So it's a great book for reference. It is not a good book for reading. Like you will fall asleep if you read 2 pages of it. But there's so much in those 2 pages.
It's a good book if you have a question.
Yes, that's what I go for.
Yeah.
Cool. So we'll get back to our case. So just to recap, 46-year-old woman has seizures, high blood pressure. She was loaded with Keppra. CT had showed subarachnoid hemorrhage. Initially, bracing reflexes were intact and spontaneously moving on her limbs. She gets transferred to a stroke center. She's tachycardic, blood pressure 180. She's febrile 100.4. She had to be intubated. Her, what's this called? Her peripheral nerve stimulator testing shows that she does not have any neuromuscular blockade effect. Propofol was stopped 20 minutes ago. She's still obtunded. She's grimacing symmetrically, withdrawing to all 4 extremities. Pupils 5, reactive. And then this is where we were trying to localize. When her eyes were held open, she has forced downward gaze. Her corneal, cough, and gag are all present but diminished. So that means her medulla is intact, cough, gag. So that's good. So it looks like all her brainstem reflexes are diminished, but they're not absent. But she does have this downward gaze that clues us into probably has some hydrocephalus going on. She has bilateral upgoing toes. So Jonique and Sion, where does upgoing toes localize to? Is that an upper motor neuron or lower motor neuron pattern?
I think an upper motor neuron pattern.
Yeah, very good. What about hyperreflexive deep tendon reflexes?
Upper motor neuron lesion.
Very good. Do you guys know what clonus is?
Yes, seen it. I'm not sure how to define it, but yeah, seen it though.
What have you seen?
So I think based on the examination, it's an area where it becomes almost like a twitch or like like a fasciculation, if you will. I'm not sure if that's how I should describe it, but it's yeah, that's all I could say.
So I've seen it. So it's people that have severe like upper motor neuron signs. You can see it in your ankles, and I saw it in a person's hand when I was in the ICU. But basically, you can take the ankle, and if you dorsiflex it, it will just continue to beat or continue to, kind of beat, and that's a evidence for upper motor neuron. And I've never seen it in the wrist, but I saw it once in a patient who was brain dead, unfortunately.
Yeah, we see it in cervical myelopathy sometimes.
Oh, sorry. What was that?
We see it in cervical myelopathies. So
Oh,
especially if you get a Hoffman test positive, you should always look for wrist clonus. You'll basically have, like, if you flex the wrist, it'll basically, and sometimes we actually see it more often than we would like to. Nurses think that this is a seizure because the patient's hand is flexed against the side rail. So it stays flexed and it's like consistently jerking. But if you relax it, it goes away.
so you said it can also be seen in cervical myelopathy?
Any upper motor neuron lesion that affects the cervical plexus. And in ICUs, sometimes seizures can be clonus can be mistaken as seizures. Like if it's a very tall person that has the feet against the bottom rail of the bed, and so your foot is automatically dorsiflexed like this, and then it kind of jerks like this because of the clonus. And the trick is to basically relax it and let it plantar flex. And if it goes away, it's not clonus. And if it reproduces when you dorsiflex it, it's clonus. I'm kind of new to this group, so if I'm talking too much, just let me know. I'm kind of trying to understand.
No, you're not talking too much at all.
No, thanks for the input.
Yeah, I'm so glad you're here. So increased tone in the bilateral lower extremities. Again, that's another upper motor neuron sign. So she gets so now because she has a change in her neuro exam, that's why they probably went ahead and got another CT head, especially with this forced downward gaze and these new upper motor neuron patterns. They get a stat CT head that shows now she has obstructive hydrocephalus with dilation in her temporal horns of the lateral ventricle, dilation of the third ventricle, acute blood in the aqueduct, and evidence of transependymal flow. So for the med students, a big thing that shows up on step 1, step 2, step 3 is knowing how to read CT scans. So for Jonique, would you like to read the CT? Let's say you're on the neurology wards and this gets pulled up. Tell me, how would you interpret scan B and scan C? Jonique, Sion, you guys can tag team it.
Okay.
Hi, I'm so sorry. I was in the kitchen doing something. I did not hear the case.
Oh, that's okay. So for our patient, because her neuro exam has changed and has gotten worse, the team went ahead and got a repeat CT scan. So let's say you were on the neurology wards and the attending pulls these images up and they say, Okay, Jonique and Sion, tell us what you see. So based upon our practice from yesterday, how would you read the CT scan?
I'll allow Janique to go with B. I don't know if she wants to take a swing at it.
I'm legit trying to figure out what I'm gonna say. Hold on.
Sion, you want to go ahead and go for B?
All right, I'll try. So same description of an axial CT head. Non-contrast. I'm appreciating, I'm not sure if that's how I describe it, but the same star pattern Matthew mentioned yesterday, in terms of the cisterns. The ventricles, I'm not sure if that's blood within the ventricles or if they've just been compressed, but I'm going to work with blood, not sure.
Good. Remember, what are the 3 things that are bright on CT?
Well, bone.
Yep.
Very bright. Blood or calcified areas.
Exactly. So we know this isn't bone because it's way too, bone, this is how bright bone is. We talked about the calcified areas of the cohort plexus and the pineal gland, and we know that that's not what this is. So what we're left with is blood. So yeah, it's blood where it shouldn't be. So what do you think about these ventricles? Yesterday, we looked at what normal ventricles look like. Is this normal or not normal?
Definitely not normal. What type
Very
of a
good.
normal it is?
Yeah, so then what's the term when you have ventricles that don't look normal? What's the medical or radiological term for that?
Ventriculomegaly, if it's like
Exactly, right. And so with ventriculomegaly, it could be exvacual, or this ventriculomegaly could be in fact a hydrocephalus type picture. And there's some ratio that I can't remember, but we used to figure out if this is exvacual versus hydrocephalus. But in this case, we know it's hydrocephalus, and a big thing that they always teach us is if you want to look for hydrocephalus, you always want to, the most sensitive area is the temporal horns, and these are huge. So Jonique, you want to take a stab at C? How would you read scan C?
okay, so this is an axial CT scan showing, I would say, bilateral ventriculomegaly. Also within the, I'm not sure if this is right, but the third ventricle there is a slight, I don't know, hyperdense area. Seemingly, Amir, put it down. It's fine. Put it back down. Sorry about that. It's my little brother.
Oh, it's all good.
Right. I don't know if I'm looking at the air fluid level, but I appreciate that there is a difference in density right there. Yes.
Here.
Yes.
So this to me looks like I think this is a ventricle. What do you, right?
It's a third
This is the
ventricle,
third
yes.
ventricle, right?
Correct. Oh, so
Dilated third ventricle.
okay.
And then this hyper dense region surrounding it, that's either a transependymal flow or blood. I would guess transependymal flow. What do you guys think?
Yeah, if you were looking at a real CT scan, you can do the Hounsfield units,
Oh, okay, gotcha.
but you can't distinguish just based here.
Okay.
But it could be early transependymal flow. And on the B scan, one thing I wanted to point out was, you see the butterfly in the center?
Uh-huh.
So you can see the butterfly in the center, and then you can see the whole circle of Willis kind of outlined. If you imagine it, do you agree? So
I would say yes, since you're telling me. Let me pull up the circle of Willis.
So circle of Willis is, yeah, pull up the shape.
So you call it a butterfly. I've always heard it as the star sign. But that's
The David
interesting.
Star of Death, yes. Some people call it the hanging dead chicken sign.
Oh, geez.
Yeah, so we don't call that anymore because these patients don't die. They actually do much better. So in the center most is the midbrain, which is the kind of butterfly shape. I can't annotate. And you can see the two ponytails of the butterfly as the two temporal horns. So the reason I say the butterfly, it's a very easy marker to find, that is midbrain. And then the circle of Willis kind of looks in front of it, although this is not a contrasted scan. So circle of Willis sits in the basal cistern. That's how you know it's subarachnoid hemorrhage.
Oh.
So everywhere there's a blood vessel, it is basically lining up along the blood vessel, and that's why it looks so tubular. Because this is where all the vessels of the circle of Willis are sitting against the base of the brain.
Oh. Let me see if I can pull up a good image for the med students.
Yeah, pull up the one that is at the base of the brain.
Okay, the base of the brain.
Yeah, there was one that I saw that, yeah.
This one?
Yep. So see how the circle of Willis is pressed against the base of the brain? Because
sorry, you guys. That one is YouTube. Oh, let's try this one.
Mm-hmm.
This one looks good. Oh, okay, well, here's a great image.
This is, yeah, so you can see the circle of Willis is sitting against the base of the brain, and the midbrain just got cut off in this section. So midbrain is just sitting on the basilar artery here and obscuring it, and the temporal horns on each side. So the blood lines the blood vessels. That's why you can see the circle of Willis outline in the subarachnoid hemorrhage base of the brain sections. And you can see the midbrain lined up as well.
That is so cool. So the butterfly sign is they're talking about the midbrain that looks like a butterfly.
Yep, that's a normal anatomy. And then the blood is lined around the midbrain, which is making the butterfly kind of pop up.
Oh.
So normally around the midbrain, you will see CSF, right? And CSF should be black, like water. But here it's full of blood. So you know there is cisternal blood. Basal cistern is full of blood. Subarachnoid hemorrhage.
Wow, thank you. Sion, Jonique, feel free to ask questions. You have the expert here.
I'm just sitting in awe.
Following.
Wondering who I get there.
Oh, awesome, thank you.
So in this particular image, you see subarachnoid hemorrhage. You see temporal horn ventriculomegaly. Then you see cisternal blood, which is around the midbrain. The lining around the midbrain they're all cisterns. And then you see just at the dashed arrow that's pointing towards the aqueduct going into the fourth ventricle. So that's intraventricular hemorrhage.
So if it's in the cisterns, I guess you wouldn't call it intraventricular hemorrhage, or would you? Or you just call it subarach?
So technically everything is subarachnoid hemorrhage. Now the subarachnoid hemorrhage is in basal cistern. The basal cistern is where the circle of Willis lives, and that's where you can see the circle of Willis outline.
Right.
Cistern means any pool of subarachnoid hemorrhage. So the two ears of the butterfly, they are called peduncles, right? Cerebral peduncles.
Right.
So the cistern in between the two is called interpeduncular cistern. So if you see blood exactly. So if you see, so how you will see neurocritical care people talk is majority of the blood was in the interpeduncular cistern. That's where the basilar artery is. So you suspect there was a basilar aneurysm.
Oh.
Now the posterior part of the midbrain has superior and inferior colliculi, correct?
Right.
That is called the quadrigemini, right? Quadrigeminal center.
For the cistern. Let me just pull this up.
So that's called the quadrigeminal cistern. So if the blood is behind the midbrain, in the quadrigeminal cistern, then you probably have a distal PCA aneurysm rupture, because that's where the distal part of the PCA comes around. PCAs walk around the midbrain like a heart enclosing the midbrain. There you go. Beautiful. So you can see how the butterfly is again very lined up. So the front of the midbrain is called interpeduncular cistern. The back part of the midbrain is called quadrigeminal cistern. And the lining of the midbrain on the sides is called the ambient cistern, because they couldn't find a name for it. It's just ambient.
Oh, that's cool.
So
I
ambient
see.
cistern blood means proximal PCA aneurysm. You can actually tell majority of the blood will be where the aneurysm burst. And the subarachnoid blood around the circle of Willis is called the basal cistern, because that's the biggest cistern of the brain, which is at the base of the brain.
I see. Oh, so that's why when the radiologists can, say, even though we didn't get a CT angiogram, they're like, oh, we think that the aneurysm is probably, MCA territory or basilar or,
Wherever the biggest clot is, that's where probably the aneurysm burst.
Thank you. I'll send this. And the great thing, because we were, go ahead.
Yeah, so you're saying quadrigeminal cistern, we're thinking of a PCA aneurysm.
Very distal PCA.
Distal PCA. Interpeduncular cistern, we're thinking of you were saying basilar? Because my understanding of the interpeduncular cistern was that it was the area that was more sensitive for an aneurysmal SAH, where the blood would start. But you're saying it is, but it's only for basilar aneurysms. Gotcha.
Because if, say, a distal MCA aneurysm ruptures, that blood would be in the Sylvian fissure, right?
Sylvian, yeah.
So, but this individual has blood diffusely in all the cisterns, but so where would you go?
I would say that it's pretty advanced, right, at this point, because it's involved with the interhemispheric fissure, it's involved in the Sylvian fissures, it's involved in the whole ambient cistern, so it's that advanced.
That means the blood really went into the brain at a very big speed, and a lot of volume was introduced into the cisterns before it tamponaded itself.
I see. Thank you. I'm going to save that in my notes for later.
And Artie, yesterday we were also mentioning the prepontine cistern as associated with perimesencephalic SAH. And that's usually, we were saying that it was usually more benign sign, or sometimes associated with venous thrombosis, though. Right? Yeah, it's really interesting.
Thank you. So now that we've talked about the imaging, so now an EVD was placed because the patient has hydrocephalus, obstructive hydrocephalus. Upon insertion, the patient's CSF opening pressure was greater than 25, which is abnormal. You want it to be less than 20. CSF drained slowly with a set EVD pressure of 20 millimeters of mercury above the midbrain. After which the patient's ICP downtrends. EVD is clamped. They do continuous ICP monitoring. Acute hypertension was treated with labetalol to maintain blood pressures. So here's another question that we had. So in some research, in this Continuum article, it talked about when the patient initially comes in and they have a ruptured aneurysm. This is before it's been secured. I read blood pressure go greater than 160, but then we've also read blood pressure go greater than 140. Is it between 140 to 160?
So the guidelines for subarachnoid hemorrhage actually will be published next year. They have not been revised since 2011. The current guidelines recommend that unprotected aneurysm, you should keep the systolic blood pressure less than 140,
Okay.
because anything higher than that has an association with aneurysm re-rupture, which has the highest incidence in the first 24 hours since onset. It is not a causation, it's an association. So we use the association to kind of reduce the risk of re-rupture.
I see.
Once the aneurysm is protected, then you let the blood pressure be whatever it needs to be.
So unprotected SBP less than 140. Thank you. After protection.
There is also one other learning point in this paragraph. If you noticed, the units of ICP change from one sentence to the other. So in the beginning, they talk about opening pressure as 25 centimeters of water. So when you do lumbar punctures, you will most often do 25 centimeters of water because CSF specific density is very close to water. And if you've seen an LP where we do opening pressure, it basically means CSF pressure goes to the 25 centimeter mark on the manometer. But if you notice in the next sentence, when they put an EVD, which is like a tube, it just connects to a very closed system called a Becker system. Now they're transducing, and there's a one-way valve, but they're transducing this one-way valve to millimeters of mercury. So you have to be very careful in using these units because 15 centimeters of mercury is equal to 25 centimeters of water.
So 15
centimeters of mercury, millimeters. 15 millimeters of mercury is equivalent to 25 centimeters of water. There are some institutes that for consistency keep everything in millimeters of mercury and never report water, because when you calculate cerebral perfusion pressure, which is MAP minus ICP, the units stay the same. MAP is in millimeters of mercury, so you also do ICPs in millimeters of mercury. But certain institutes prefer to use water for CSF, so you have to be careful in the units here.
I see.
Yeah, that's a pearl, very important one. Yeah.
Thank you. So then, okay. So, but normal ICP, you want that to be less than 20 millimeters of water?
20 centimeters of water.
20 centimeters of water. Okay.
Yes.
Thanks. Okay.
Which
And
would
then
be
when
like,
you read,
which would be 12 or 13 millimeters of mercury.
oh, so when I'm reading the ICP, I want the ICP to be less than 20 millimeters of mercury.
This is where the literature forgets to check their units, and people make so many mistakes in literature that they don't think about it.
Oh. Okay. I see. Thank you. Let's see. Blood pressure less than 140 to prevent aneurysm re-rupture. So they do a repeat CT head that shows the hydrocephalus is reduced. And then now, Jonique and Sion, why do they do a CT angiogram? This goes to what we talked about yesterday.
To localize the specific area or artery that the bleed is coming from.
Yeah, because we want to know, why did the patient have the subarachnoid hemorrhage? What is it due to? Is it due to a vascular etiology? If so, what kind? Because if it's a ruptured aneurysm, that's something that surgical that the neurosurgeons can go and treat.
Right,
So
or if it's
very
venous thrombosis, I believe Mattia was mentioning yesterday.
Oh, say that again?
Or if it's venous origin, I believe Mattia was mentioning that yesterday.
Yeah,
And
so
for
the
that, you
venous
do
origin,
some coiling or something like that.
yeah, the venous origin that he was talking about has to do with the mesocephalic, I said that word wrong. Subarachnoid hemorrhage, where, let me pull, I think this paper should have one.
I think you said the word perfectly this time.
Oh, you think I did? I feel like I always
I think you
butcher it.
did.
Really?
I think
Oh,
you
you're
did.
too kind. Let me see. Let me stop sharing, then I'll just look for an image for that.
Did you get the reference I sent you? I tried sending you a reference via email yesterday, unless you got it.
Oh yeah, I got that and I
Oh, you got
saved it. Thanks.
Because I think those would be, if I recall correctly, those would be pretty good.
Okay, let me show that reference then. So here's the paper that he sent out yesterday. So these are different patterns of subarachnoid hemorrhage. A is more aneurysmal, and then C is that perimesocephalic aneurysm bleed. Can you guys see that, or should I make this bigger?
Can you
So-
zoom, please?
Okay, yeah, let me. So unlike with the aneurysmal subarach, where it's, you know, the star patterns and all the different cisterns that we talked about earlier, this one's really just localized to, oh, what's the name of the cistern? Who wants to help me out?
Prepontine.
What was the name of it? Prepontine?
It's in front of the pontine, right? So all the
Yes.
cisterns are named pretty intuitively. So there is interpeduncular cistern, quadrigeminal cistern, ambient cistern at the midbrain level, prepontine and peripontine cistern at the pons level, and premedullary cistern at the medullary level. That's it.
I see. And then so the arrow, what's the name of that? The pontine, is it interpeduncular?
That would be
No,
at
that's
midbrain
the
level.
prepontine. The
Oh,
interpeduncular is between the peduncles.
Oh, okay. Thank you. Thanks.
So that's the
Okay.
pons, yeah.
Cool. So that's what you were talking about, Jonique, and that this one, the hypothesis that it's more so like a venous etiology versus an arterial etiology for a subarach from an aneurysmal subarachnoid hemorrhage. So we'll go back here.
And also I have, I tried sending you 2 more screenshots via email yesterday. I may have failed, but I've sent them here, and they're 2 pictures from the Anne Osborne's textbook, which talks about the perimesocephalic
Oh, do you want to
non-aneurysmal
share it?
SAH. Yeah. So they're I've sent them via the chat now.
Oh, cool. Or I mean, do you want to share it on your screen?
Oh, sure.
Or are you good?
Absolutely. So
Thanks.
these would be the non-traumatic SAA sublocation being helpful, and exactly what we were talking about, the aneurysmal SAH mostly arising from the circle of Willis, exactly as Artie was beautifully outlining along the basal cisterns and the Sylvian fissures. And then these 2 special types of SAH, and this is, by the way, the interpeduncular cistern we're talking about. But the 2 patterns would be around the midbrain and anterior to the pons, called the perimesencephalic non-aneurysmal SAH, probably secondary to venous hemorrhage. And this is.
And remember, mesencephalic basically means midbrain. So peri means around, mesencephalic means midbrain.
Oh, mesencephalic, perimesencephalic.
And
Nice.
then the second pattern. There you go.
Perimesencephalic.
And the second pattern is the convexal SAH, which is along the convexities. And here, depending on the age of the patient, it's either an RCVS kind of picture, if they're young, or cortical venous thrombosis or amyloid angiopathy if they're old. So it's just along the sulci. And I've shared those screenshots on the chat for people who want to store them.
Thank you. Nice. So then let me scroll back to the case. Give me 1 second. So they did a follow-up CT that suggests an anterior communicating artery cerebral aneurysm. Patient undergoes digital subtraction angiography, which shows the presence of the anterior communicating artery cerebral aneurysm with thrombus. So let's go to figure 3. And here's the digital subtraction angiogram. And this is showing the aneurysm. And for the med students, you guys really, I've never seen a digital subtraction angiogram shown up on your step 1, step 2, step 3. So I won't go into details about how to read it because I think that's more so for residents. Let's see. So then they go and they successfully coil the aneurysm. That's figure 4. Oh, that's so beautiful. I just love vessel images. Oh, so beautiful. So that's the aneurysm that's secured. So now, so that's pretty much.
And I think this is also, since yesterday we were briefly, one of the math students was talking about clipping the aneurysm, and Artie, I'm sure here can chime in and help us, but I know that there are different techniques that are now used. Coiling is one, and clipping is another one, although now with some stents, you can do some really refined coiling of aneurysms. And in some cases, you can also embolize the aneurysm. And then also, I think there are some other devices with flow diversion that can be used, where you just divert the flow, and then the aneurysm will end up having stagnating blood, and it will essentially form a clot and die off. But there's a lot of new techniques that can be used for that. It's really an exciting time to be in this area.
Oh, and then I think this paper, let me show you, goes into a little bit of detail, like you said, Mattia, about the different techniques. So there's surgical clipping, there's endovascular coiling, and do they talk about, and then there's stenting. And what I've seen, I haven't seen a lot of, I feel like well, I'm not a neurosurgeon, so let me not talk about what I don't know. But yeah, so those are the different techniques. So that's cool. So now the learning point from that case is what they're going to discuss with us here. So this is just a classic presentation of hyperacute subarachnoid hemorrhage. Big things are you want to get blood control managed. You want to get emergent imaging to figure out where's the source of the bleed. If it's ruptured, if it's aneurysmal, then you want to call neurosurgery so they can intervene and stop this bleed before it gets worse. So I think that's the big takeaway from this case. So now we can go to the second case. A 55-year-old man with type 2 diabetes and chronic back pain goes to the emergency room after sudden headache originating from the posterior neck and radiating to the top of the head. Headache is improved when he comes to the ED. He doesn't have any other neurological symptoms. He did have some neck manipulation by chiropractor the day before. Patient doesn't have any alcohol or tobacco use. He takes metformin and naproxen for pain daily. On exam, temperature, he's afebrile, blood pressure, 150s over 80s, heart rate within normal limits, respiratory rate, he's a little bit tachypnic. And then he is setting normal on room air. He's alert, he's oriented, cranial nerves, sensation, and strength are all intact. Laboratory values are normal, except for he has elevated glucose, and then his urine drug screen was negative. So then he undergoes a CT head without contrast. So before we read what they say, Sion or Jonique, would you like to interpret the CT scan for us? Let's just for you guys, what you'll typically see is something like C or D on an exam. So what do you see?
Well, for C, I'm seeing the same premesencephalic foci or area, as well as it going a little laterally. I'm not sure the name of that cistern. So in the prepontine area anterior to the pons.
Good. So sometimes I have attendees tell me, before you make your diagnosis, tell me what you see. So if you're writing your radiology report, how would you describe what you see?
Okay.
Kind of like what we talked about yesterday. You want to go through all the steps.
So my only concern now is, do I describe this as a hyperdense area, which it really isn't relative to bone. It's in terms of density, I'm not sure how to describe it.
Okay, so is this a CT or MRI?
CT scan, certainly CT scan, axial view, or CT head, axial view.
Good. Is it with or without contrast?
Without contrast.
Yep. Very, very good. And you said axial cut, very good. Now you can get into the pathology if you see anything. So what do you see that's abnormal?
All right, blood anterior to the pons. So and you guys described that earlier as the premesencephalic or prepontine cistern.
Yeah, I think you can say there's hyperdensity or hyperdense regions within the cisterns that's concerning for subarachnoid hemorrhage. And I would just leave it at that.
Okay.
Yeah, the amount of blood is a little too much for, and this is something you gain the knowledge by seeing a lot of these scans, but the amount of blood is a little too much for perimesencephalic, because see how they're pointing the arrows? The blood is in the sylvian fissure on the left side in picture D. It's all around the midbrain. So it's perimesencephalic, but it's also going behind around the vermis. So that's the vermis in the center. That's the cerebellar vermis. And it's the amount of blood is a little extensive here. And then in the C picture, that's the lower part of the midbrain going into the pons. It's pretty extensive there as well. And you can kind of see the temporal horns on each side in the middle cranial fossa. So they typically should be slit-like, but I would call them early hydrocephalus here.
Okay, makes sense.
Good, awesome. So one thing, when you're describing images, try and they always say, tell us what you see. And then after you describe it, then you can talk about, well, here's my differential, but always tell us what you see, because you can't go wrong if you use the right radiological terms. Cool. So we looked at the CT head, shows subarachnoid hemorrhage, and all these different cisterns. And there we go. So this is atypical for a benign aneurysmal subarach. Why is that? Is it because it's so extensive, and is it because received in the vermis?
Yeah, it's also, I think, because it involves the Sylvian fissures, which is more so what Artie was describing as something involving the circle of Willis vessels. I think the picture of a perimesencephalic benign SAH is more so weights restricted to the prepontine cistern, for instance. Here it's everywhere. I think it's a better explanation would be if it started as an aneurysmal SAH, and there was just so much, they just continued going to the prepontine cistern and so forth. Correct me if you agree, Artie.
Yeah, I think you're absolutely right. And in my world, always assume all subarachnoid to be aneurysmal until proven otherwise. So, because the downstream effects of missing an aneurysmal subarachnoid is pretty high, and perimesencephalic aneurysms are pretty rare in general. You also need to know that with time, so every 6 hours pass since the CT scan, some blood is going to get absorbed. So if you look at the data, at 24 to 48 hours, 50% of the blood gets absorbed. And if you come at 7 days, half of the CT scans will actually be normal. So if you come after 7 days after the worst headache of your life and you had a full-blown subarachnoid, half of the CT scans can be normal. So depending on patient's presentation, some blood may have been absorbed. So an extensive subarachnoid may look less extensive. That's why that little hyperintensity along the fissures really is an important sign not to miss.
But what I am confused on, so I understand in a perimesencephalic subarach, I get that, and I get the normal pattern for the aneurysmal bleed, but what makes this atypical for a because I would have seen this and said, oh yeah, this looks like it's probably due to an aneurysmal subarach because it's so diffuse.
I think that's what they're saying.
Yeah. What the article is saying is that it's atypical for a non-aneurysmal. So it's typical for.
Sorry.
Yeah.
Okay.
So
you're agreeing with the article.
Thanks. So we get a CT head. Okay. CT head is not performed because of the contrast allergy. So they do a digital subtraction instead with 3D reconstruction. There was no abnormalities detected. There was no aneurysms detected, and there was no vertebral artery dissection detected as well. Patient goes to the neuro ICU. They start on clobetasol drip for blood pressure less than 140. He's monitored, neurochecks every 2 hours. He started on nimodipine, 60 milligrams orally every 4 hours for prevention of delayed cerebral ischemia. Undergoes daily TCDs to monitor for vasospasms. He undergoes MRI brain and cervical spine and MRI angio of head and neck to evaluate for cold abnormalities. So this is interesting. I would have assumed that the digital subtraction was more sensitive than an MRI angiogram.
It is in general, but if the DSA is negative the first time, which 5 to 10% of even aneurysmal subarachnoids can be negative. Different institutes have different protocols. Some institutes repeat a DSA in 7 days and do find a small subset of patients that now show an aneurysm where it did not show before, because the assumption is that the aneurysm kind of clotted. So you could not find it because it's already clotted, but then it opened up again. So it needs to be protected. Some people end up doing a brain C-spine protocol because a very small subset, but significant subset, ends up having a neck aneurysm that ruptured and just kind of traveled upwards the subarachnoid blood, or AVFs in there. So that's why the follow-up imaging sometimes can be brain and C-spine, both MRI and MRA. In general, MRA for the brain is not the preferred modality because it only gives you the first and the second degree vessels. So the initial part of the MCA, and then after the bifurcation. By the time you get to the third level branches, M3, M4, MRA loses its sensitivity for any pathology.
Yeah, I
I
was gonna
see.
say, would you, in an ideal world where this patient did not have a contrast allergy, would you go ahead and do a CTA instead?
So it depends on your institute. If your institute has a 64 slice CT scanner, then a CTA could be as good as a DSA. But most likely you should probably get a repeat DSA, because you can do a low contrast DSA protocol. You can't do a low contrast CTA protocol. So a follow-up imaging in 7 days, DSA is actually better than a CTA because of the contrast load.
I see. Thanks. Other than disc abnormalities, MRI and MRA did not detect any abnormalities. Patient stays in the new ICU for the next 7 days, remains neurologically intact except for headache and neck pain, treated with Tylenol, stays on IV clobidopine for hypertensive control, and then insulin for hyperglycemia. Patient undergoes repeat DSA post-op day 7 after being pre-medicated for contrast allergy. Again, no cerebral aneurysm or other vascular abnormalities were detected. Strict blood pressure control to systolic blood pressure 140 with IV antihypertensives was no longer indicated, and he was weaned off clobidopine. So now that's interesting. So after, that's also a good point. How long do we wait before we say it's safe to liberate the blood pressure? 7 days?
So 7 days it's safe, but remember, after 7 days, even the primary prevention guidelines.
Strict blood pressure control. I guess because they didn't find any evidence of an aneurysm, ruptured aneurysm, so
they probably kept him there for 7 days, which is a little surprising. But after 7 days, you just let them be normotensive or whatever their blood pressure needs to be. But remember, the American Heart Association guidelines for primary.
The teaching point from this case, let me get my.
Iselza, can you hear
hello?
us?
Sorry.
Yeah. Oh no, I was just wondering whether you could hear us, because I think Carty was finishing off a point. Could you hear her?
I'm sorry. Sorry, no, I couldn't hear her. Sorry, I can hear you guys now. Sorry.
Okay.
Oh.
Yeah, so the point I was trying to make is that after 7 days, if you look at this patient, you treat this patient for primary blood pressure goals as American Heart Association recommends. So if you basically, I go to the doctor and say, hey, what's my blood pressure goal for me? That goal is now 130 by 80. It used to be 140 by 90. So even by that measure, you should still keep it less than 140, but we don't keep it as strictly from a subarachnoid perspective.
I see. So after 7 days, we can not be as aggressive, or would that change had we, had we found a ruptured aneurysm status post coiling? I guess how long should we have strict blood pressure go status post securing of the aneurysm?
After securing, you let them be. You do not control their blood pressure, because if the patient has autoregulation intact and they go into spasm, they'll actually raise their blood pressure themselves. And you actually want them to be whatever their blood pressure needs to be.
To maintain cerebral blood flow and naps. Okay. Thanks. Cool. So let's see what they have to say. This case illustrates benign clinical course of non-aneurysmal subarachnoid hemorrhage. We talked about the CT head. Although most non-aneurysmal subarachnoids have a benign course, in atypical cases, patients can develop delayed cerebral vasospasm, delayed hydrocephalus, and even rebleeding from an occult aneurysm that was not initially visualized on DSA. So I guess that's why this patient was in the ICU, so that we can monitor for subarachnoid complications and perform repeat imaging to make sure that the patient, we couldn't find some vascular cause. Cool. So now we get into case 3. So case 3 is 70-year-old
just
female.
a question for the group, if you guys don't mind. Is there any specific reason why they were not going for nicardipine? Because nicardipine is what they've seen mostly here for in terms of drips for blood pressure control. Is there any specific?
They talk. There's actually a table because we use nicardipine too at my hospital. So maybe this table. Let me find it. Nicardipine. Sorry, never mind. That's nimodipine. Yeah, I've seen we use IV labetalol actually in our hospital. So I don't. Who knows?
So the difference is in pharmacokinetics. Cleverapine is very rapidly titratable. You can titrate it pretty much every 2 minutes to 5 minutes. The onset of action is 1 to 2 minutes. And if you become too hypotensive, you can actually stop it and it gets out of your system in 15 minutes. Compared to nicardipine is a great drug, is the choice of drug for subarachnoid as well. It takes about 45 minutes to work and it lasts in the system for about 6 to 8 hours. So the rapid titration, if the patient is very hemodynamically unstable, they're very sensitive to medication. Cleverapine is usually the better medication in this case. The second part is if you know that the patient is going to be clipped or coiled very soon, and they're already coming into day 3 or day 4 in high risk of vasospasm, you don't want nicardipine in the system too long. So cleverapine is just very shorter acting and shorter lasting and very rapidly titratable. The third reason to use cleverapine instead of nicardipine would be heart failure or any other condition that predisposes you to volume overload. For the same amount of drug that you use, nicardipine will give you much more volume per ml compared to cleverapine. So nicardipine at the max dose of 20 milligrams an hour may end up giving you 50 to 75 ml an hour of fluid because it has to be mixed in fluid, compared to cleverapine, which will only give you 5 ml an hour.
That's brilliant. Yeah. Wow.
I did not know that.
There used to be a cost difference, but now cleverapine is as cheap as nicardipine. So everybody's actually going towards cleverapine. The only challenge is it has lots of triglycerides in it because it's kind of made in a lipid-rich emulsion. So if you have hypertriglyceridemia or if you're prone to it, you have to keep checking it occasionally. And if you're allergic to egg yolk, if you're allergic to eggs, you can't use cleverapine.
Huh. Does it ever become a problem when you have propofol and clevidipine?
Yes, I think the triglycerides become a real problem because they can go up to 800, 900 within 24 hours. Now, for the med students, if your triglycerides go up to 900, what's the complication I'm worried about? Why can't I just let the blood be rich in triglycerides for a few days? It's a non-neuro question, nothing to do with neuro.
Repeat your question, RT, please.
So if you have hypertriglyceridemia to very high levels, say 700, 800, what is the common side effect of that as an organ dysfunction that you need to be worried about? It has something to do with the organ that makes insulin.
Oh, acute pancreatitis. Is what you're thinking?
Yes, good job.
Nice.
Oh, that makes sense.
And what is the most common? What is the most common lab abnormality you will expect because of severe hypertriglyceridemia?
An increase in the lipase?
Not unless you get pancreatitis, no.
Sodium? Is it sodium? You'd have an abnormality for hyponatremia?
Good job, pseudo-hyponatremia. Awesome, guys.
Nice. So now for case 2.3, so we have this 70-year-old female, 70-year-old woman, history of hypertension and smoking, found unresponsive in the bathroom. EMS found her obtundant with minimal respiratory effort and a weak pulse. She was intubated and brought to the emergency room. blood pressure, she was hypotensive, temperature 98.2, sinus tachy 110. She has some PVCs. Her glucose is elevated at 220. Her UBS is negative. Her extremities are cold and clammy. O2 is 92% on 80% FiO2. Laboratory values are significant for elevated creatinine, elevated lactate, and then elevated troponins, and then a leukocytosis. So I'm going to stop there. So for the med students, when you see hypotension and you see cold and clammy, and then patient has elevated lactate, and then elevated troponins, what are things you should be concerned or thinking of?
As patient
An
is
MRI?
okay.
A what?
I was asking if you'd be concerned about an MI.
Yeah, well, more so like cardiogenic shock.
Right, cardiogenic
It's,
shock.
yeah, like why, so that's something to keep in mind. But yeah, so leukocytosis, EKG shows QTC prolongation and T-wave inversions without any ischemic changes. So that tells us, well, she's not having a stem, she's not having a STEMI. They do a bedside ultrasound that shows this left ventricular contractility with apical akinesis and ballooning, consistent with Takotsubo cardiomyopathy, which is just a stress-induced cardiomyopathy. She has pulmonary edema in her lungs, so that explains why she, has low saturation. They put in a central venous catheter and they started her on norepinephrine infusion. So why do you think she has to be placed on norepi, Jonique or Sion?
Well, because of the beta receptors that are on the heart. So when you infuse norepinephrine, that's going to improve the contractility of the heart and improve the blood pressure and perfusion to tissues.
Very good. Yeah, great. Good job. So, and we want her to keep her blood pressure or her MAP above 65 for adequate blood pressure, for adequate blood flow to her brain. So now that we've taken care of her ABCs, now, and she's not on any sedative medications, now, we can figure out, well, why was she obtunded in the first place? Why was she, what happened?
I have one question here. If norepinephrine is given, wouldn't that cause likely a reflex tachycardia? Since she's already tachycardic, I'm not sure if that's of significance.
That's a good question.
So it depends. If the reflex tachycardia was in response to hypotension and your hypotension gets better, the beta receptor reflex goes away, then it may actually get better. But it's a great point. So you should watch for tachycardia with norepinephrine. But that's a great point.
Okay.
And I think that in this case, though, at the end of the day, you gotta focus on the fact that this person is in shock right now, right? So you need to treat the shock. And of course, it's a risk. You're absolutely right that they may worsen the tachycardia. And of course, if you worsen the tachycardia, you could also just worsen the blood pressure, but you gotta find where the whole circuit started from, right?
And the other part is you don't have many choices here. So do you know your vasopressors? What other vasopressors do you have except for norepinephrine?
No one called ephedrine or
Epi, yeah. One more.
Phenylephrine.
Yes.
right.
So which one does not cause tachycardia?
I think the phenylephrine.
Yes.
Because that's what we call peripheral vasoconstriction. So
Right.
Yes. Good job. Now, phenylephrine is the only one that doesn't cause tachycardia, but what is the effect of phenylephrine on myocardial contractility? Or what is the inotropic effect of it? Is it positive? Is it negative?
I don't think it has a positive inotropic effect.
Mhm.
Right.
It actually
I
is.
think negative.
Right.
It actually has negative inotropy at high doses.
Right.
So
Okay. So it
look at.
wouldn't benefit.
Yep. So what do you want more? Are you willing to compromise tachycardia, or are you willing to compromise reducing ejection fraction?
I'll compromise tachycardia. I'd prefer the ejection fraction improvement.
There you go. Good choice.
Oh, this is such great learning. I love this. I'm loving this. So we start her on norepi, so we can get her MAPs greater than 65. Patient is without any sedative medication, so we try and do the neuro exam. So for the neuro exam, no response to noxious stimuli, sluggish pupils, but they are reactive at 4 mm, forced down gaze, limited vertical and horizontal eye movement on oculocephalic maneuvers, diminished corneal reflexes, and absent cough and gag. So for Mattia and I, so now I'm going to localize where I think, what I think is going on. So she is not responding to noxious stimuli, so that's not good. So that's involving the motor and the sensory pathway. So probably something's going on in her cortex. Her pupils are sluggish but reactive, so that's probably just a medication effect. That means her cranial nerve 2 and 3 are intact. She does have forced down gaze, so that's concerning for elevated ICP, or what we talked about with midbrain compression. The limited vertical and horizontal eye movement on oculocephalic maneuvers. So that's the doll's eye, but she's not fixed. So are they saying that she has fixed?
I think it's the equivalent of what we would see with the gaze preference, right? So there's the paresis, not a plegia. And I think this is starting to be concerning, not only for increased ICP, but also for ponting involvement. So it could be that the blood is irritating the pons, and it's definitely affecting.
So when they're saying limited, so with doll's eye in the comatose patient, fixation is bad.
I'm assuming she doesn't bury the sclera, right? So it's not pure doll's eye, but she doesn't bury the sclera, so there is some movement on the oculocephalic maneuver. That's how I'm reading this. And it's kind of the equivalent of what then they're saying with diminished corneal responses. I'm assuming that there is some corneal response, but it's not as full as we would want for a cranial nerve 5.
I think people get confused with doll's eye movements because of the kind of dolls they are used to. Some dolls have fixed eyes. Some dolls have eyes that kind of rotate when the doll moves. So traditionally, doll's eye movement basically, when it's present, means an eyeball that stays looking ahead when the head moves. So your oculocephalic movements are actually intact. If your eyes move along with your head, as if your eyes were painted on your face, that's called absent oculocephalic reflex, or so that's where confusion comes, because people are exposed to different kind of dolls.
So then how would you interpret when they say limited vertical and horizontal eye movements on oculocephalic maneuvers for a comatose patient? That is, it's throwing me off.
That means eyes are going along with the face.
Okay, and that's normal. We're good with that.
That's not normal. Eyes going along with the.
For a comatose patient?
Yep, for comatose patients, your eyes should stay straight. And when you turn your face to the left, your eyes should kind of go towards the right, because you're looking straight ahead.
I thought for a conscious patient, their eyes will remain fixed, right?
So it depends. Yeah, conscious patients, the patients will resist any eye movements. They will look towards wherever you want to see, because they'll have saccades.
Okay, but then for a comatose patient,
if their eyes move like they're painted on their face, then that's abnormal. If their eyes move separate of the face movements, that means brainstem is intact.
Okay.
And Artie, how I was reading limited vertical and horizontal movements is that on doing oculocephalics, you cannot get them to bury the sclera, right?
Exactly. This is the most biggest point of confusion in brain depth testing, because people are exposed to different kind of dolls.
I'm so confused. Who wants to
So-
share their screen?
Yes, let me do this. Let me act it out so you can see.
Okay.
Okay. If I'm awake, is my video working?
Uh-huh.
If I'm awake and looking at you, you make me look this way, my eyes is going to follow where you want me to look, right? Because my brain
Yes.
is making me look wherever the face goes. Now, if my brain stem is intact, but I'm deeply comatose, okay, I'm kind of looking straight ahead. You move my head, my eyes stay anti-gravity. I move this way, my eyes stay this way. So my eyes are actually moving. My eyelids are staying the same, but my face is moving this way. That means my brainstem is intact.
Okay.
Now, if my brainstem is gone, I move my eyes, you move my head. It's kind of moving as if my eyeball was stuck in my head.
Okay, I see. So now so a normal person who's awake, they're gonna fixate on the object.
Exactly, because they have saccades. Their frontoparietal ocular reflexes are intact.
So then when I turn my head, and I'm still gonna be looking straight ahead, even though my
Yes.
head is turned this way.
Yes, that's normal because you want to look that way. But if you were deeply comatose, look towards the left. So if you're deeply comatose and this is how your eyes move, and I may move you to the right other side, and your eyes go with your head, that means your eyes are not moving independent of your head. That means
Okay.
if you're deeply comatose, that means your brainstem is not intact.
Okay, I see. But if I turn my head this way, but the comatose patient is able to look straight ahead,
Mhm.
then it's normal.
That's brainstem is intact.
Oh
Is that-
man, I had that completely wrong. Oh,
Am I
goodness.
correct in that, or am I? That's what I understand, because we talk about
No,
this in brain.
you're the consultant. I had it wrong.
Yeah, we do
my
this in
head.
brain depth test. We get this wrong in brain depth testing all the time.
Wow. Okay.
So,
Thank you so much.
Mattia, was I correct?
Yeah, 100%. 100%. Yeah, I think the confusion, and this is what confused me at some point too, is that if you mix comatose patient with aware patient,
Mhm.
it gets confusing. But I think
Yes.
just thinking of comatose and the fact that their cortex is not working, right? And it's that's where the saccades are no longer interpolating there.
And I also realized that one of the med students actually showed me a video of a doll, and they said, "Look, this is dolls' eye movements." And I realized people have different kind of dolls. Some dolls that have eyes that move, and some dolls that eyes are stuck.
That was also the problem that I had in med school. I'm like, what doll doesn't move their eyes?
There are dolls that have eyes painted on them.
Yeah, you're right.
So I know in one of our previous sessions, we had talked about the brain death. Now we talked about the neuro ICU exam, and we talked about the doll's eye. Okay, never mind. I need to write that out. Okay, never mind.
I think this is why we discourage the use of doll's eye. We basically say bury the sclera is a good way to say that.
Oh, burying the sclera. Okay, so if they're able to bury the sclera, then it's normal.
That means brainstem is normal because see, my sclera is visible on this side.
Yeah.
And if I move my head and I'm comatose, I'm burying the sclera, right?
Oh, okay. Thank you.
So burying the sclera is a more physiologically accurate term.
Oh, I'll write that down. Thanks. Burying the sclera. Thanks, y'all. This is why this study group is so beautiful. Now I understand doll's eye. No oculocephalic maneuver. I'm going to stop using doll's eye. Cool, cool. So we're concerned. So this is bad, right? This is bad, right? Limited
Correct.
vertical and horizontal eye movements. So that's bad. So we're concerned that their midbrain is being compressed or is bad. Okay.
And remember, this patient also has diminished corneals. So we're going to the fifth nerve now, an absent cuff and gag. So there is brainstem ischemia happening. And why would this patient be brainstem ischemic?
Because cardiogenic shock. Probably, this person probably has a brain bleed.
And I'm also concerned about the increased ICP. So I'm concerned about poor perfusion, which of course may be due to the person being shocked, but also increased ICP, right? So if we think about our Monroe-Kelly doctrine, right? We have low MAPs here. We also have increased ICP, so probably the perfusion pressure will be very low. So we
the two
may
things
want...
are happening. So ICP is going up. In reflex to that, you should have an increased CPP, but that increased CPP is not happening because the patient is in Takotsubo cardiomyopathy. So a brainstem ischemia is happening because of low CPPs.
Low
And
CPP.
I think, by the way, something interesting that we talked about quickly, but for the med students, you know, we always talk, for some reason in med school, we always talk about Takotsubo cardiomyopathy in the event of a psychological stressor, which is, you know, it's true, but also any kind of stress can cause Takotsubo cardiomyopathy. And in neurology, at least, we think about Takotsubo cardiomyopathy a lot with, especially with SAH. And I think that's something that, at least, you know, in my med school wasn't stressed. You know, it's like stress cardiomyopathy as only psychogenic stress.
There's a very good article in Brain. It's probably 10-15 years old now. It was called the brain-heart connection. It actually gives you a very good pathophysiological review of why you get stress cardiomyopathy with anything wrong with the brain.
Yeah, and let me guess, that was written by Marty Samuels, right?
Authors, I don't remember. I'm not good at remembering names.
Because he also talked a lot, and I don't know if you've come across this, Artie, too, but he also talked a lot about the insula being sort of the cardunculus.
Yes. Yep.
And
because
that's
it's
so
the
interesting, yeah.
It's the cortical center for the autonomic nervous system.
Yeah.
Look up circulation, not in Heart Journal. The journal should be circulation.
Is it this journal, brain-heart connection?
No, the journal is called Circulation, I think. And the title is called Brain-Heart Connection.
Yeah, and maybe this is like a fun fact more than something useful, but there's something interesting about the.
Yep, that's the one.
There's something interesting on the same along the same lines on the voodoo death.
On what death? Voodoo?
Voodoo, yeah. Very cool. And in thinking about next best steps here, I think, you know, we have going off of what Artie was saying, you know, we have the maps now. We focused on those with the nor-epi and with pressors, but then on the other side, we need to start thinking about the ICP. So thinking about ventilation, thinking about the head of the bed, and also further thinking about ways to decrease the intracranial pressure with either an EVD or a bolt at this point.
Beautiful transition.
Do you guys agree?
Yeah.
Yes, the only thing is, Bolt is not the preferable choice because these patients do have a high risk of hydrocephalus eventually. So we actually prefer EVD when we can, because you can drain the CSF. So we try not to put bolts. The only time we put bolts is TBI.
Interesting, interesting.
Then we do a stat CT head that shows subarachnoid hemorrhage in all the ventricles. So if we go to that image, ooh, that is bad. So they have intraventricular extravasation of the subarachnoid blood. It's in all the cisterns. It's diffuse. You see the butterfly pattern. It's in the vermis. It's in the lateral ventricles. It's in the sulci. It is everywhere. So, and they do a modified Fisher grade of 4 for the subarachnoid hemorrhage. So because of hydrocephalus, they do an EVD that was placed, and then CT squirts out because of high opening pressure. Patient was taken for angiogram, which shows a large basilar tip aneurysm that was successfully coiled. So let's go and we look at that image. Oh, that's so pretty. Look at that. Basilar, here's the basilar artery, here's the tip, here's the aneurysm that ruptured, and then here's status post coiling on the digital subtraction angiogram. Patient was admitted to the ICU. They continued vasopressor support for cardiogenic shock. Patient is intubated for hypoxic respiratory failure. Patient remains obtunded and only grimaces sluggishly and withdraws to noxious stimuli. After 5 days, her neuroexam shows no improvement. They do an EEG, which doesn't show any signs of seizures. Her EVD was occluded from blood clots, so they had to replace it multiple times. Her ICP remains below 20 millimeters of mercury. Troponins peak at 15. She develops SARS, which I believe they no longer use that term anymore. I think that's outdated. With persistent fever requiring targeted temperature management with acetaminophen and continuous surface cooling. They do an infectious workup and she's found to have gram-positive pneumonia, so they treat her with broad-spectrum antibiotics. She also now has acute kidney injury with oleuria and rising creatinine. Given the patient's multi-organ failure, high-grade ICH, patient is transitioned to comfort cares with compassionate extubation. That's a really sad case. So basically, this case is just illustrating that not everyone who develops a subarach has good outcomes. Actually, I've read that some people who develop subarach don't even make it to the hospital because it's a very deadly disease. But with the advent of neurocritical care, we're able to improve mortality, morbidity for patients that have subarachnoid hemorrhages. So this case is just illustrating posterior circulation, aneurysm rupture with several complications, including Takotsubo, cardiomyopathy. We talked about the cardiogenic shock and how we would treat that. We talked about the EVD placement and how if you have, and this is more so for us, the residents, with subarachnoid hemorrhages, there are several complications that we'll have to monitor for that include the heart, include the kidneys, include seizures, include delayed cerebral ischemia, and include hydrocephalus. Cool. So we move on to the next case, case 2-1B. So wait, did I? Oh, is this? Huh. So this is case 2-1B. Oh, that's weird they did that. It looks like we got to go back to 2-1A. So 2-1A was the lady with seizures. Then we gave her Keppra. She had the forced gaze deviation. She had obstructive hydrocephalus due to subarachnoid hemorrhage. We placed an EVD shunt. And okay, she status post coiling. So now do a lot of scrolling. Okay. So now she status post shunt. She goes into the ICU. She's intubated, sedated. They do a chest x-ray. She has some gross aspiration. They do a bronchoscopy to remove some. So that's just one of, complications of, subarachnoid hemorrhages and being intubated. There's, you can get maceration. And if you don't treat that, that can turn into, no, she had seizures. So I think the seizure, maybe she vomited with the seizure. Then they had an intubator to protect her airway. And now that they've secured her aneurysm, they do a chest x-ray and it shows that she did in fact aspirate. So they do a bronchoscopy where they take a scope to look and see if there's any evidence of mucus plugging, or to see, sometimes they can do the scope to get like, what they call it, sputum samples, so they can look at it under a microscope to see if there's any evidence of infection. But they also can use the scope to remove some gastric content that helps with her oxygenation. Now we want to do a neuro exam, so we turn off sedation. Patient is able to open her eyes to voice, and she obviously follow commands. Brain stimulating flexors are intact. So that's pretty good. Moving all her extremities. That's pretty good. So that means her brain stimulating reflexes are intact. She's doing all her extremities. That's pretty good. So now we start her on nimodipine 60 milligrams Q4 hours for 21 days to help with. So here's the question I have. So I read in this article and in the podcast that nimodipine does not decrease the risk of vasospasms. But
That is correct.
Everyone says, oh, we give nimodipine to decrease the risk of vasospasms. So are we giving nimodipine to decrease? So what does nimodipine really do, and if it's not affecting the vasospasm incidence, or is it just DCI?
The biggest trial. So this is the challenge. This is the big paradox in subarachnoid research. We have at least had 3,000 different agents tested. The agents that fix or improve radiographic spasm do not improve outcomes. The only agent that ever improved outcomes was one that was nimodipine, but it did not improve radiographic vasospasm. We think that the vasospasm has nothing to do with the outcomes. It has something to do with the neuroprotective effect of nimodipine, because the effect cannot be reproduced by other calcium channel blockers. And it also emphasizes the fact that mortality and morbidity in subarachnoid does not come from vasospasm. It is actually a neuroinflammatory cascade that has to do much more than just the plumbing clogging up because of spasm.
Thank you.
So essentially, nimodipine entered clinical practice for the idea that it would prevent the spasm, which it doesn't do by serendipity. We found that it helps maybe the root cause of morbidity in SAH.
It wasn't serendipity. It was very good phase 1 trials and trials in animals. So there are several rat models and rabbit models of subarachnoid. And because DCI, delayed cerebral ischemia, is such a preventable disease if you look at its pathophysiology, that's why we were looking for mechanisms to abort the inflammatory cascade that causes delayed cerebral ischemia. So this was identified as one of those agents. So 3,000 agents have been tried. This is the only one that ever showed change in outcomes at 3 months.
Wow.
So now, because of clinical seizure-like activity that she had initially on presentation, She was continuing on Keppra, 1,000 milligrams for seizure prophylaxis. I want to call it prophylaxis here, but anyways. She was also started on low molecular weight heparin for DVT prophylaxis on post subarachnoid hemorrhage day 2. She was extubated. She was oriented to self and place, but not time. She was drowsy. So now, because she's now going to be in the window for vasospasms, we screen with transcranial Dopplers. We want, they give her fluids to maintain euvolemia. And let's see, post-op day 5, she now is developing a fever. She has a leukocytosis. They do an infectious disease workup that's unremarkable. They do DVTs, or they look for DVTs with the ultrasound, but it was unremarkable. They start her on Tylenol for fever control. She doesn't have any, so let me ask the medical student. So in this patient who has been intubated, has been in the hospital for about 6 days, who had aspiration, who previously aspirated, now 5 days later develops a fever, what are some things you would want to do to look for why she has a fever?
You say something, friend?
Say that
I was
again?
No, I was gonna say that you'd want to get a sample, or I'm not sure what test you do, if it's a lavage or whatever it is, but to see if she has some gastric contents, because she may have aspiration pneumonitis. If that's a possibility. So you want to check for that.
So when the patient's in the hospital, what are some common things that they can develop that would cause them to develop a fever and a elevated white cell count?
A pneumonia, a UTI.
Yep, good. So then if we think a patient has pneumonia, what's an image that we'll want to do to look into that?
Chest x-ray?
Right. So you listen to their lungs, see if they have any abnormal lung sounds. And if so, even if they don't, especially in the ICU, because they're intubated, so it's, in my opinion, it's hard to hear lung sounds. So you get a chest x-ray to look for any evidence of any consolidation in their lungs. And then getting the chest x-ray. If you don't see anything, then you look for other sources of infection. You can get a urine analysis and urine culture to look and see if there's any evidence of a UTI. They also get blood cultures as well. Here, they also got CSF studies.
Right.
I don't know if I would have gotten a lumbar puncture on her, given that she was improving from a neurological standpoint. I don't know. I don't know. I guess before you would kick the bucket and get the lumbar puncture, they were looking for evidence of meningitis. So what are some neurological exam findings that you would see for a patient that has meningitis?
I think in terms of signs, there's one called the Koenig sign on examination.
Yeah, very good.
And Brudzinski, or I'm sorry if I'm mispronouncing that. Brudzinski's sign, Koenig sign is basically an examination where the patient lies supine and you, with the legs extended, you flex at the hip as well as at the knee joint. And if the patient is unable to fully extend at the knee, that's a positive Koenig's, I believe.
Go ahead, I'm listening.
And Brudzinski's sign is flexion at the neck, will result in flexion at the hip as well as at the knee joint, which are signs positive for meningismus, which is irritation of the meninges as a result of meningitis. I guess other non-specific neurological examinations could be elicited on examination. I guess that depends on the extent of the meningitis, whether there is a meningitis or meningoencephalitis.
Yeah, very good. So those are the two big things we do. Then we also test for neck stiffness, lift their neck off the bed and, rotate it left and right and see if there's any neck stiffness. Yeah, very good. So they do a CSF and out. So those are the big things. Usually, first thing, if I see a patient in the ICU, they have a fever, they have leukocytosis, do chest X-ray urinalysis. You also want to do a thorough skin exam because these patients have been laying in bed. They could have, cellulitis, or they could have, form, decubitus ulcer. So you always want to do a thorough skin exam. What else would I check for? And then if there's high suspicion for encephalitis, meningitis, get the LP. So all this is negative. So another thing you can do that can cause fevers and the leukocytosis in patients are blood clots in the legs. So that's why they got this ultrasound to look for that. And it was normal. So what do you think is causing this patient's fever? If we looked at common causes of infection, they all come back normal. She doesn't have any clots in her legs. So then why is she febrile?
I think a couple of other things that I would have possibly checked. I'm curious what you guys would think, but I would definitely want to send like a beta D glucan and a galactomannan just in case. But that being said, this is the NS ICU, so and she has an SAH, so something that we may think about, of course, are central fevers. But I think a cool thing to think about for medical students too would be something along the lines of also medication that can cause fevers, like you can get it with the neuroleptic malignant syndrome and serotonin syndrome. Not this case, but I just think it's something to think about.
Remember, blood in the brain it's very pyrogenic. And for residents to know, an infection in a patient with an EBD is actually considered a hospital-acquired infection and gets us what we call as the HAC penalty or the PSI, the adverse events that are coded by CMS, and we actually get fined for that. So there's a huge emphasis on preventing hospital-acquired infections.
Yeah, and in this case, that's where we think of going back to what you were saying about the SAH. That's where you would think about a central fever, right?
Yep.
Mm-hmm.
So what explains the leukocytosis is my question.
So that could be what we call as a SIRS response. I think we were right in saying that we don't use this the term SIRS anymore in relation to sepsis, but that inflammatory response that can be seen in non-septic conditions, we still use that word a lot. Okay. So you will still rule out infection. The other thing you can do is you can actually send a CSF lactate level. So studies have shown that because CSF is going to have proteins and leukocytosis from the fact that it has blood in it, right?
Right.
So CSF cell count is not going to help you. So CSF lactate can be helpful. If the CSF lactate is pretty high, that could mean very acute blood. But if it is persistently high, then you can have kind of a concern that there is a bacterial infection. Obviously, you have to send gram stain and cultures.
Okay, thank you so much.
So she has no focal weakness, but she is impulsive and delirious. She has tachycardia, range 100 to 110. She has hypertension, blood pressure is 170s, 180s. Her TCDs are 2.9 on the left and 3.2 on the right, and which concerns for a mild vasospasm on the right middle cerebral artery. So post subarachnoid hemorrhage day 6, she still remains febrile. Now she's developing large urine output, and her plasma sodium is dropping too. So now she has hyponatremia. She has elevated urine output, concerning for cerebral salt wasting. So that's just one complication of subarachnoid hemorrhage. So now she then develops bilateral lower extremity plegia with increased tone. Her ICP pressure is normal. So why do you guys think she has developed bilateral lower extremity plegia with increased tone, when yesterday her neuro exam was normal, except for some confusion?
I'm thinking the raised intracranial pressure. I don't know.
That's a good guess, but it says here her ICP is 15, so that's normal.
Okay, yeah.
So what else do you think? I would say it has to do with, my thought would be, I would say this
That makes sense.
either it could be a vasospasm, which is bilateral lower extremity plegia with increased tone. That would localize to more her spinal cord.
But is this an expected thing? Like, is this an expected complication, or having not known this literature, how would you have expected this in this patient? I mean, patient presents as such. What would be your first suspicion? What would you think?
Yeah, that's what I'm trying to figure
I think
out. So
I think whenever you see whenever you see a bilateral lower extremity plegia in a patient with something else going on in the brain, just to be vague, I think there's an area which is the bilateral ACAs, and the bilateral ACAs can explain a bilateral plegia. And you can see this with the subfalcine hemorrhage, and with the subfalcine herniation. So I'm kind of wondering if there was something going on along those lines right now.
Yeah, if the ICPs were high, falcine herniation would explain AC involvement. If there was a sagittal pathology, again, if this was a sagittal meningioma that is impeding on the ACOM and bilateral AC origins, suprachiasmatic lesions. So these are the kind of lesions that will cause bilateral lower extremity pathology caused by something in the cranium. But bilateral AC involvement is the most common. Or you had a single ACA, and then
like an azygos ACA.
And a single ACA was supplying both the right and the left ACA, which is not uncommon.
That's called an azygos ACA, I think, right?
Yep, azygos ACA.
Yeah, azygos, yeah.
So it's due to the vasospasming of the, or is it due? Now I'm confused. Is it due to vasospasming of her bilateral ACAs?
Yep. So both the ACAs are causing contralateral leg weakness. Remember, ACA supplies the parasagittal area that supplies the leg.
Interesting. Sounds like this. Oh, interesting. Oh, that's
remember
cool.
your homunculus?
Yeah, because for me, I was localized on bilateral lower extremity plegia. That's spinal cord, but she has a subarach. So what is going on here? Okay, that makes sense. Cool. So because of that, we want to give her fluids. So we give her normal saline. We do repeat CT scan, because anytime you have a patient that has a brain bleed and there's an acute change in their neuro exam, you want to get a CT head. So that's what they did here. We were looking for any evidence of an infarct, more so in her worsening hemorrhage or hydrocephalus, and it's normal. So we started her on nimodipine infusion because we want to maintain her blood pressures between 180 to 220. Now that she is vasospasming, we want to increase her blood flow to the brain. So she undergoes angiogram that shows vasospasms in multiple segments of the anterior cerebral arteries. Nice call. So they wanted to look at image 11. And so here in A, This is the ACA, and these arrows are showing that she has multiple segments that are vasospasming, or that have reduced caliber in the blood vessel.
And I think as well as just staying on that A image, because I don't know, maybe our math students are more oriented than I am, but I always had trouble with this. So I think it's helpful here to think that this is essentially a coronal image, and the vessel that you see on the left is really lateral, and that would be an MCA, and instead the one we see medially, which is on the right, is your ACA, and they're both popping off your ICA. I don't know, maybe our math students were more with it than I was in their stage of training, but I think it's helpful to. And
No,
that's the
yeah.
and right there is the vasospasm that we are describing right now.
I wish I could. Oh, I can annotate. Oh, sorry, y'all. We could have been annotating a long time ago. Oh, new next level. Ooh, next level. Cool. Thanks for that. So now we'll make this our last case, since we're having so much fun. It's past 8 o'clock. Let's see, where were we? Okay, so how do I get rid of this?
Yeah, I was gonna say, unfortunately, the annotation is coming with you. That's
Clear.
Oh, well.
Clear. There we go. Clear. Cool. There we go. So it shows multiple vasospasms in the middle cerebral, and we saw some in the interior cerebral artery as well. So they give her intracranial nicardipine through both internal carotids. Her neurological exam resolves. She's still on the norepi drip and for her high volume urine output and hyponatremia with salt wasting, we give her IV fluid boluses, and she's also started on fludrocortisone that helps with her polyuria. So now post-op day 8, she now has bilateral lower extremity weakness again. The angiogram shows severe bilateral anterior artery aneurysms. They now do angioplasty of the anterior cerebral arteries, and they give her more nicardamine infusion, and her symptoms resolve. Over the next few days, she's on supportive therapy. I'm skimming this for anything important. Patient does not develop any more neurological symptoms. Her clinical exam improves. Her polyuria is improving. She's now more alert and oriented. She's weaned off her vasopressor. Her EVDs removed. She's now out of the ICU, and she looks great. And then she goes home. Oh, that's a really good case. So this case was just basically illustrating the complications that can arise status post coiling, and basically in the day 3 or day 21, that's when patients are at high risk for vasospasming and cerebral salt wasting. So this just really illustrates, how we go about managing that in a patient that has subarachnoid hemorrhage. And for medical students, this is, just FYI, fun facts. I don't think that, at least here in the US, medical students are not expected to know this amount of detail in managing a subarachnoid. Big things that for you all to know is, what is the etiology behind the subarachnoid, and how can you identify it on a CT scan? That's the big things that tend to show up on your shelf exams in step 1, step 2, step 3. And I think that might be the last case. If not, I think we've done 5 cases. And then I don't know, Mattia, this article, if you haven't, it does a really good job of just talking about the different complications of subarachnoid, one being delayed cerebral ischemia, and then how to go about treating hyponatremia and anemia, and fever, seizures, and then volume status. So this is a really good article.
Yeah, I haven't had the chance to actually go through it in detail, but I definitely will, yeah.
Referring to, yeah. Awesome. So part one, we talked about thunderclap headaches, the differential, what you want to do next, get a CT head and the CT head so subarach. We talked about, sorry, let me back up. We talked about thunderclap headache. We talked about what are some of the things you want to do on your neurological exam for a patient that comes in with thunderclap. And then we talked about what is your first lab or testing you want to get. You get a CT head if it shows subarachnoid hemorrhage. Today we talked about, management and steps and imaging and, ICU level of care. And in that, with the med students, you guys learned how to read CT scans. So we're pretty much done talking about subarachnoid hemorrhage. So tomorrow we're going to talk about intracerebral hemorrhages. So I think that's on the schedule. Let me look and see. Or did I give us a break because of the holidays? Did I give us, let me look at the calendar.
I think it's still on tomorrow. Let me see.
So what I
Yeah,
I may have done is I may have just scheduled for the 24th and 25th without thinking, but let me see what I sent out in the email, because the email talks about what topics we're doing. So let me just share this screen with everyone so that everyone can see what's coming up. So, okay, so the 23rd, which was today, so we just finished subarach. So then what we'll do on the 26th after Thanksgiving is we'll pick up with ICH and then stroke. Stroke may take 2 days. So we'll just push all this stuff down. And that's the beautiful thing about our study groups is that we can change the schedule as we see fit based upon, what we would like to learn. So hope everyone has a great holiday. Happy Thanksgiving. And I will see everyone on the 26th, where we'll talk about ICH and then management of stroke in the ICU. And thanks for everyone being here. We were on for almost 3 hours, and that just goes to show how much, all of us love neurology and love talking about neurology. And thanks for being here. Thanks for being on, because one of the reasons why I created the study group is to recreate the study groups that I had when I was in med school and grad school, but doing it in the COVID virtual setting. And I think the amazing thing that I didn't know that was going to come out of this is that we were able to learn from each other across specific Atlantic oceans. So thanks everyone for being on. And the cool thing is too, is that we're able to learn from each other, who all of us have like different learning levels. So, everyone from pre-med students to seasoned attendings and everyone else in between. So it's been phenomenal. It's been fun. And I look forward to our discussion more. And if anyone has any questions or other resources or things that, you think can make the study group better, I'm all ears, I'm open.
And as always, thanks Rosa for organizing. This is, as I say every time, this is awesome.
Oh.
And Artie, thanks so much for your contributions. It's been wonderful. And MS students, great job. As we asked you very tough questions. So I hope you had fun.
We did. I can speak for we're having too much fun. So thanks to you guys as well.
Yeah, I'll try to join as much as I can. Appreciate it.
Thank you so much, everyone.
Were really amazing, and I look forward to every single session here on out. But this was really helpful. Last night was helpful. Tonight was really helpful. and I look forward to further sessions. As usual, I'll make every effort to attend as many as I can. I look forward. Actually, this makes me pretty excited for neurosurgery or neurology, which I think are focal areas that I'm interested in. So thank you guys, every one of you.
So Isiosa is a PGY3 resident, is that correct?
No,
Yeah.
no, it's a student for me still. Oh, Matteo, I'm not sure if you're asking about Matteo. Yeah, and yes, I think.
Got it.
Oh, yeah.
Okay.
Yeah, I'm a PGY3 resident at Mayo Clinic, and I am actively applying for stroke fellowships.
Awesome.
Thank you.
Thank you, guys.
Have a good night. Happy holidays.
Happy holidays.